I'm also on faculty at the Kennedy Krieger Institute and Johns Hopkins University School of Medicine, and I feel like it's always important for me to tell you a little bit about my background because I have sort of varied interests. I was trained as an occupational therapist and practiced for a while, and I have a master's degree in exercise physiology. And now I have a lab here at Kennedy Krieger and Johns Hopkins where I study walking and balance for people who have conditions that actually just change over time. So adrenoleukodystrophy is one of them, but I study other conditions as well, and I think that's sort of helpful for understanding how best to improve walking, is to look at how other pathologies affect it as well. So I'm telling you all of this because I'm going to talk to you today about walking and tools that are available to you to keep you walking safely. But I tell you this from my knowledge as a scientist here, from my research, my research here, and so I have to I have to be sure that everyone knows that that what I'm telling you is based off of the research that has been done on AMN as well as other conditions, and I'll try to point out specific things that I think are important for you to keep in mind as you're trying to keep yourself as mobile as possible. And I'm happy to take questions as we go. If I can figure out how to make my slides work, hold on. Okay, so I was asked to give these reminders. So everyone who joins the webinar is automatically on mute, but you can ask questions, just type them out and push them through to me, and I'll do my best to keep up with all of that. And if I don't talk about your question right away, then I'll try to go back to it at the end, and I hope I don't miss any. And I'm told that no one except for me will be able to speak during the presentation. There's a disclaimer. This information and services provided by ALD Connect are for informational purposes only. So definitely it's important for you to know that this should not be a substitute for professional medical advice or seeing a physical therapist or an occupational therapist who's treating you individually. And ALD Connect does not recommend or endorse any specific physicians, treatments, procedures, or products, even though I may mention some of those in this particular talk. That's, again, based on my research, so it's just my way of sharing that information. And, of course, at any point, if you don't want to be part of this, you're free to close out. I hope this is helpful to you. So I'm going to go through 5 different areas. I'll first review some basic features of walking and talk to you a little bit about how someone can look at walking and how we break this movement of mobility or walking down into separate pieces. I'll also review elements of a walking evaluation, and many of you may have experienced this, and sort of explain some of the features that we're looking for. And then I'll describe kind of common problems that people have with walking. Then I won't be able to cover everything, but I cover sort of the ones that I've seen the most, I guess. And then I'll describe treatment options, and I'm definitely open to other things that I have not included in here, and that would be a good thing to include in our discussion at the end. I'm happy to address any questions as we go and at the end. So we know that changes in the central nervous system affect walking. Now this can be just from age. So as you can see, this little girl here is walking, and the way she walks while holding this pail is going to change as she ages. We also know that events like a stroke can change walking, and conditions like adrenoleukodystrophy, and specifically adrenomyeloneuropathy. And so this gentleman here has AMN, and that's the area that I've spent many years studying, is individuals who have what I call AMN, which is adrenomyeloneuropathy, how the central nervous system affects walking in that condition. And as you can see, this gentleman is using a cane, and that's just one way to substitute for ways that when things are difficult when you walk. Now, we talk about walking, when we talk about this for research, we describe walking by the phases of the walking of the gait pattern. So there's a stance phase here, and that's characterized first by heel strike here on the right foot, and then as you put your weight on that leg, your foot is flat, Mid-stance is when your body is directly over the leg, and then push-off is when you're literally pushing your foot into the ground to push yourself forward. So this whole portion from heel strike to push-off is considered the stance phase on the right leg. Now, eventually that right leg will also be pushed off the ground and be in a swing phase. And so this schematic is meant to show you that there's an acceleration phase where the leg goes from being behind the trunk to mid-swing, where it's more directly below the trunk, to deceleration, where it's actually preparing itself for the heel strike phase, which comes again at stance. So this is nothing new. This has been, people who are interested in mobility have used these terms of stance and swing for quite a while. And I tell you them because I think the more you learn the vocabulary, this might help in understanding some of the details of what you think may be affecting your walking pattern, and it gives us a vocabulary to work from. Now, if you talk about how we evaluate walking or gait, there are several different features that I think are important and are going to seem really obvious to you once I bring them out. So one is just how long your step length is. So in this picture, it's how long you go from the right foot on the ground to the left foot on the ground. That's your step. Your stride is actually how far it goes. Your right foot goes from stance here to push off here. To stance here, sorry, from stance to stance. And so this is important because the length of your step is going to determine how quickly you can get from one place to the other. Now, the width of the base of support, so how far apart your legs are, is also important for your balance. So we know that if you keep your feet very close together, your base of support is narrow, and so your balance is going to be more difficult to be maintained. So if you have trouble with balance, think about widening your base of support. So these are two things that we often look at when we're looking at walking abnormalities. There's also a component of, there's also a component of center of gravity. So this is meant to show your pelvis here and the back of your spinal cord. And what happens is that your center of mass is carried about here. And this center of mass actually goes up and down with each step. So it goes up about an inch and then down about 2 inches. And so that's the extent of your center of gravity moving as you take a normal step. Now this changes if you wear different kinds of shoes. This changes if you have weakness in your legs or weakness in your trunk. But this amount of mobility at your hip is what we look for. More than that is not good, and less than that is not good either. Another part of walking, another thing we look for is how far you can laterally shift your weight. Excuse me. So you start with your center of gravity in the center of your body, and then as one leg goes through the swing phase, you have to, in order to lift that foot off the ground, you have to literally shift your weight over to the other leg. And that's what this big orange arrow is intending to indicate. You have to shift your weight over so that the right leg can hold up the whole left side of the body. As you stand straight, your center of gravity should be maintained in the center. But then as you take a step, each step you will shift your weight one direction and then the other direction. But again, it can be fairly stereotyped for people who have normal strength and normal muscle tone. Another thing, sorry, so frustrating. Okay, another thing we have is pelvic rotation. So when you look overhead at someone, you can see that the pelvis does some movement as you take a step as well. So as you bring your right foot forward, your pelvis is going to rotate about 40 degrees forward with your leg. And so as long as we know what we expect, so we expect about a 40-degree angle change, that's normal pelvic rotation. What happens is that as we get weak or our muscle tone changes, then the pelvic rotation becomes less or too much, and that brings more problems. There's a common test called the Trendelenburg test that many physicians and physical therapists alike use when they're looking at someone's walking pattern. So I showed you in the previous slide that if you look overhead, your pelvis goes forward and back as you take a step. Also, if you watch someone from behind, you can see how much their pelvis goes up and down as they take a step. Now you have to imagine, as this gentleman is taking a step with his right leg, the whole left side of the body has to be maintained, has to be holding up the right side of the body. And so what we expect is that there'll be some increase in the pelvis as the right leg is being brought forward. And that's a negative Trendelenburg test. That's normal. A positive Trendelenburg test is when this left side of the body is so weak, for example, that it can't hold up the whole right side of the body as you take a step. And so what happens, instead of your pelvis rising as you take a step, it drops. And it drops sometimes fairly substantially. I'll show you a picture of someone walking in the laboratory with this kind of walking pattern. But that's a positive Trendelenburg test. And that tells us that the hip muscles here on the left side are too weak, and they're not able to hold up the right side of the body. Now, this is a snapshot of the laboratory. Now, what we do, this is a model here that we have. And essentially, she is showing that we can put infrared light-emitting diodes on different parts of the body. We put them on bony landmarks, right? So these don't change with weight. They should be consistent each time you put them on. We put them on the shoulder, the hip, the pelvis, sorry, the hip, the knee, the ankle, and then the fifth metatarsal, which is where your fifth toe is. And we do this on both sides of the body. And then we have a camera system called the OptiTrack Motion Capture System. And it's not really a camera, it's more of a sensor, and it senses these infrared light-emitting diodes. And this is carried to a computer where we can construct a stick figure of the person walking in the laboratory. Now this sounds, it sounds more fancy than what might be necessary, but what we found, or what scientists have found overall, is that the more detail we can get from these markers, the more we can see subtle changes that may be occurring. And this can lead us to understand better why walking is falling apart. Now I'm going to show you, this is a healthy individual in the laboratory who is wearing those same markers I just showed you. They do have a head, even though the head did not have a marker on it, so you won't see that here. I want to show you just what normal walking looks like. I mean, you've seen this. I'm going to show it a couple of times and point out a couple of features. What I want you to see is just how smoothly the left and right legs move, how the trunk moves, but it's kind of a rhythmic pattern. And it seems fairly symmetric. Now, we all have a little bit of asymmetry, but the symmetry is also an important component of this. I'll show it one last time. So that's to give you this idea of what healthy walking should look like. Now, what we do, we put these markers here on the pelvis, the hip, the knee, the ankle, and the foot. And we do this so that we can look at the angles at each joint. So we can look at the hip angle, the knee angle, and the ankle angle. And this is going to give me the ability to show you what we call walking kinematics for a single stride from heel strike to heel strike. And for a control subject on this left column, and for an individual with AMN on the right column. So let me just point out some features here. So the top row is the hip angle, the middle row is the knee angle, and the bottom row is the ankle angle. And the x-axis is time. So time 0 is when heel strike occurs. And then the white arrows indicate where the toe pushes off the ground. And then the end, where this pink dotted line is, that's heel strike again for the same side. Okay, so it's one single stride for a control subject. And what I want you to notice first is just the distance these pink lines are. It took this control subject about 1.25 seconds to do a single stride. And it took this AMN individual about 2.25 seconds to do a single stride. So the first thing you notice is how much longer, how much slower they are, right? Another thing I want you to notice is just the differences in the angles. So hip angle here, this is extension of the hip. And you can see that the AMN subject has a much deeper hip extension, okay? I want to really point out this knee angle because I think this is kind of the most vivid example of what we see quite often with individuals who have AMN. And that is, when you have heel strike, you expect your knee to bend a little bit and then extend, and then to flex or bend again quite a bit, and then to come back to extension. What we find in many AMN men and some women is that the knee stays at a particular angle and doesn't go through this big excursion of flexion and extension. Now, we think this is because of this high muscle tone that occurs, that is not under your voluntary control, and as a result of the condition, of the pathology of the disease, but it also is a sign of weakness. So if you can't control your knee because your knee muscles are weak, it's probably safer to keep your knee at one angle and try not to move it very much, right? So it's a little bit of a strategy perhaps too. This is what is unclear still. If you look at the ankle angle, what you can see, this point right here for the control subject is ankle plantar flexion, where they're pushing off. And what you can see is the AMN subject doesn't do that very much. So they should have a drop in this yellow line, and they don't. And that's because another thing they're not doing is they're not pushing onto the ground with each step. So they're not propelling their leg forward as smoothly as the healthy control subjects are. And that's probably because they have weakness and spasticity at their ankle as well. So I show you all this just to give you an idea of how much detail we can go into just to understand walking. It's that complicated of a movement. Now, other things we do in the lab, we measure walking in lots of different ways. I showed you how to look at walking kinematics, but we can also do timed walking measures, and this is what's more common in clinical trials. And that's because you don't need as much fancy equipment. You can use a stopwatch, and there's a variety of ways to do it. So one thing that we do is the timed up and go test. Not shown down here at the bottom. It sounds kind of hokey because basically all you do is you have the person sit down on a chair. You say, I want you to walk about 3 meters. You have a target here at 3 meters. And you say, I want you to start seated in the chair, stand up, walk past the line, turn around and come back, and do that as quickly as you can. And that's called the timed up and go. You basically measure how fast they can do this. Now, it was initially brought up, this test was designed for the elderly because it was getting at this idea of more than just walking a straight line. This is a little bit more of what life is about. We stand up, we sit down, we go to one direction, we change directions, we come back. So it's supposed to give a better measure of functional walking. A second walking measure is called the timed 25-foot walk. And that's just like it describes. It's essentially how fast can you walk a straight line of 25 feet. And we'll mark off beginning and end, and we'll time you for that. A third thing that we use is a 2-minute walk test. This is to get at walking endurance. So what we do is we have 2 cones that are separated by, I think, 40 meters. Don't quote me on that number. And the idea is I'll give you a go, and I'll say I want you to go walk around the cone, come back to the next cone, and keep going in this circle pattern for 2 minutes. And I want you to stop at the end of 2 minutes, and we're going to calculate the distance you went in that 2 minutes. So this is meant to get at the idea of endurance. And then there's something called fast walking velocity, and people use lots of different ways to measure this. You can just use a stopwatch and measure out a certain distance, or you can use what I'm showing here on the right. So this is a Xeno walkway. And I should say this is put on by a company called Kinetics. And what it does, it has sensors all along the bottom here. And the sensors allow us to quantify exactly where the foot is placed as you're walking along this walkway. And so we have the ability to have this kind of device in the laboratory so we can get precise foot placement information. We can determine step length, step width, all those things I initially talked about when looking at walking. It gives us a little bit a better way to quantify walking than just using a stopwatch. But each of these walking measures has an advantage in some different way. And this is what has made it difficult to determine what is the best way to measure improvement in walking in AMN as well as in other pathologies. Okay, I'm going to talk about common gait problems and try to describe as best I can some things that I think about when I think about the AMN population. So many times what I see individuals struggle with is when they take a step, they drag this right foot along. And this is because this muscle right here, the anterior tibialis anterior, is too weak. And so its job is just literally to lift the toe so that the foot can clear and you can take a step. And so that's why this term here at the top, poor foot clearance. Many of you may have heard it described as foot drop. Another way to compensate for this weakness in this tibialis anterior muscle is to just bend the knee more, right? That's called more of use a kind of a steppage gait. The knee is lifted higher than it needs to go, but this at least allows the foot to clear the floor as you take a step. Now what you notice with either of those strategies is that when the foot lands on the ground, you can hear it. So you end up with kind of a slapped foot, and that's because this muscle is weak, and so it's weak as it contracts as well as when it relaxes. So it's important to sometimes that's what most people will notice the most is the sound. I can hear myself walking, they will say, because you hear this flap each time. Now another thing that can happen with individuals with AMN is that you can have a weak gluteus medius. So this muscle is in your buttocks, and what it does is it gives your hip the stability that it needs so that when you're taking a step with the left leg, the right gluteus medius is strong enough to carry much of the weight on that right leg. Now when the gluteus medius is weak, what happens often is that the person will lean their trunk over to still get that lateral shift, but they overcompensate, so they lean too much. And so what happens is as you might imagine, is your hip gets hiked up so that you can lean, so that you can bring it forward. Another problem is a weak gluteus maximus. So this is another muscle in your buttocks, the more superficial one, and it's going to control your hip in a way that when it's weak, what you end up doing is leaning back further so that you end up in more hip extension, which is what I showed you in that kinematic slide, if you remember, so that the AMN individual had a greater hip extension angle, and we think this is probably because this gluteus maximus muscle is weak. So let me show you an example of someone who uses a hip hike strategy. So I want you to watch this left hip as they walk. And you can see that as they bring that left leg down kind of tenderly is how I describe it. But what I want you to notice is that the left hip gets raised up more than it should compared to what that healthy control subject that I showed you earlier did. So I'll show you one more time just so you get the idea. So this person is using a hip hike strategy. All right, another problem is this, you have quadricep muscles here on the front of your thigh. And these get weak as well in AMN. And so what you might notice is either a crouching strategy where your whole body kind of slowly sinks, or you end up with a hyperextension of your knee because you can't control the knee because of this weak quadricep muscle. So let me show you what this might look like in an individual. That left side is hyperextending. She can't control the knee, so instead of controlling it, she just lets it go into hyperextension and uses the whole leg straight as her stability, allowing her to still take a step with the right side. Now, as you can imagine, this is pretty hard on your knee, so this kind of strategy is effective, but it's dangerous for your knee and for your low back. Okay, so what are some treatment options? There's a lot of them, so I'm just going to talk about the ones that I could think of that seem to make the most sense for AMN. There's strength training, right? I meant to replace this slide to make it more descriptive. There are lots of different ways to do strength training. We'll start down here at the bottom. I mean, there is essentially just using your own body weight to strengthen muscles and to strengthen your muscles. And so this is a bridge exercise what you do is you lay on the ground, you bend your knees, and the idea is you want to lift your hips up and hold them there. And it sounds easy, but if you can keep your knees separated, then you're forcing your body to use the abdominal muscles and your gluteal muscles combined, which is what we do in normal functional behavior. So this kind of exercise is nice because it's forcing you to use groups of muscles that are necessary for walking. So that's meant to just explain that there are a lot of muscles, a lot of exercises you can do that don't require weights. This is another example where this person is doing a squat where you lean against the wall and you start out standing and then you sink down, so that the idea would be to really have a 90-degree angle here at your knee. This is a little bit more than a 90-degree angle, so I would tell the person to stand up just a little bit. You don't want to strain your knees too much, but this will work your quadriceps quite a bit. There are other ways though too. There's lots of different equipment at gyms that can be modified and could be very helpful for increasing your strength as well. Now, many people talk to me about exercise. I'm an occupational therapist, but from my research, what I notice is that exercise gives you lots of advantages when you have AMN. So it gives you some control over your body, and it allows you to compensate for some problems. Now, when you describe weakness, there are two kinds. I like to emphasize this, that there are two types, right? There's the primary weakness, and this is due to the primary disease process. So you have weakness because AMN affects the motor pathways that go to the muscles of your legs. So one way to deal with that is to learn compensatory interventions. Energy conservation is one example. You know you have a certain amount of energy every day. You need to plan out your day a little bit so that you can make sure you can get what's important done that day. But this may require rest breaks during the day. This may require that you organize your activities so that the most strenuous things are done in the morning, or you can make sure you can ask someone's around to help you with some of these more strenuous activities. So that's compensating for this idea that you have weakness. Now, what I'm talking about with therapies would be the idea of affecting secondary weakness. So with secondary weakness, this is usually avoidable. And the idea is that this occurs because of decreased activity overall. So it can be minimized by early intervention and appropriate follow-up. And this means the more active you can be, the better to a certain point, but that you need to go to a physical therapist, go to your physician, and ask them what's the best method for me to deal with my weakness. You can do many things in the gym on your own, but I really suggest getting guidance to be sure that you're not just strengthening the stronger muscles, but really emphasizing the muscles that are weakest for you. We have in much of our research found that there's a tendency for your hip muscles in AMN to be weak. So that would be an area that could be emphasized in a home exercise program or in an exercise program that you do at a gym or within a group. Other exercises that I think are really effective would be something like yoga or other Pilates, things that are available at gyms. Also, you can use YouTube or things that you already have at hand. Exercising does not need to be expensive, but it needs to be thoughtful. So that's my biggest pitch, is that it should be something that you get guidance for. Physical therapists are there, trained to determine which muscles are weak and give you the guidance on how to strengthen them. Now, another way to get strong or to improve your walking is just to walk on a treadmill, right? Now, I'm going to arrange the next several slides in the same way. So I talk about what I think are potential risks, what I think are potential benefits, and then at the bottom I usually talk about a question or variations or things that you could that might make it easier for you to do this. So I'll start with the negative. So the potential risks of being on a treadmill are kind of obvious, right? There's the potential for falling. So you need to keep up. You need to make sure that you have kind of an emergency button because if you've ever fallen on a treadmill, it's very painful because of the the belt will keep moving. So that's the important thing, is to be able to stop the belt if you do lose your balance and fall. I also would recommend this model here in the picture is not using bars, but there's often bars that you can hold on to, and that doesn't take away from the kind of exercise you're doing. As long as you're not bearing a lot of weight with your hands, if you're just using it for balance, it's very effective. Another risk of being on a treadmill is that you have to keep up with the speed of the treadmill. So be really conscious of not of paying attention to the speed. Another risk is that you can overexert yourself. I think you could do that with any of these treatment options. You get overly enthusiastic, you try really hard, and then the rest of the day you're beat and you can't do any more. And so the rule of thumb I like to use is that you should, after about an hour after you exercise, you should be getting your strength back and be able to do more again. But you might need a little rest after you exercise. If you need more than an hour, then maybe you've done too much for that day. Now, potential benefits include it allows you to increase your walking speed more than just walking outdoors would, right? Because you can push that belt to move faster. It has obvious cardiovascular benefits because you can walk at different speeds, at different angles. Also, you can do this in any weather, that kind of thing. Another thing that I think the women especially need to be aware of is that walking and most exercise really has benefits for bone density. And that's a really important thing that we need to watch over time. Now, variations that have been brought up to me, some in the AMN community, is, of course, walking over ground is very effective and very useful and far less boring than what you get on a treadmill. But for people who live in areas that are not as accessible, a treadmill does work. Another person in the group suggested that, what they do is they listen to music and they choose music that is at a pace that will keep them walking faster. So that's a very clever idea because this allows you to move more, walk a little faster, and you might not even be thinking about it. You're just keeping up with the music. So you can choose music to promote that. Aquatic therapy is another really great treatment option. So there are risks. It's of course costly, in part because you need a pool, right? And in part because you need the equipment once you're in the pool. It's also more time consuming because you have to get into a bathing suit, you have to deal with your hair, you have to get out of the pool, deal with getting out of your bathing suit, so it can be a little bit more time consuming. It's non-weight bearing, which the negative to that, again, is that it's not really good for bone density reasons. But if you did this in combination with other activities, then that risk would be far less important. And the other risk or negative to it is that it usually requires some kind of skilled assistance. So you need either a safe way to get into the pool and out of the pool, and you need a temperature that works well for you. If it's too hot, this might not be as comfortable, and you might not be as motivated to work as hard. Now, there are a lot of benefits, though, to aquatic therapy. So one is that it's a very good strengthening tool. Also, there's reduced risk of falling because the water literally supports you. And as you can see with this woman here on the left, there are bars or even the wall that you can hold onto as you walk. The other really nice thing about being in the water is that you can alter the resistance, right? So the faster you move your leg, the more resistance you're pushing, right? So water gives you some natural resistance, but it doesn't feel like a weight. So many people say they don't notice it as much. It doesn't seem as arduous as it does when you're using weights. And then many people just tell me it's just more fun. It feels like I can do more in the water. I like getting together with my friends and we can do water aerobics, or even like what this woman is demonstrating is you can do walking or running in the water where you don't even touch the ground. And so what you do is you wear this this belt that just is a buoy, just raises you up in the water, and these little foot slippers essentially provide a little bit of resistance because they're again made of foam where they're more buoyant. So you're having to push your legs down to keep them under the water. Same thing here. What this woman is holding, these are made of foam too, so that when you push them down underwater, you're having to use your muscles. So there's a lot of ways to modify activity or exercise in the water. That's a really, really great option. Now this is something that I think many people have overlooked because it looks so simple and it has not been pushed very much with individuals who have neurologic injuries, but I think it has a lot of potential. So let me explain. It's called taping. Kinesio taping is what some people refer to it as. You may have seen this in people who've been in the Olympics. Athletes have these, bright colored tape on their shoulder or on their leg, and what it does is it's just literally athletic tape, but it's special because it has a certain amount of elasticity to it. And so what science has found is that when you put the tape in appropriate areas, it literally pulls on your skin and on the fascia below your skin. And fascia is like this substance that's kind of like a sticky spiderweb substance. It's all below your skin and it keeps your muscles kind of cohesive together. So if you can pull on that fascia, you see some really interesting results. So the risks are that if you're allergic to tape, this would be a problem because you literally leave the tape on day and night. You can shower with it, and it works by pulling again on the skin. Skin irritation is another potential risk, and it requires a skilled therapist that knows how to do this, but the benefit is that they can teach you or a caregiver how to do this onto you because it's not that hard once you've figured out how you're going to use it. But that initial stage of figuring this out, you definitely need a physical therapist or someone trained in kinesio taping. The benefits, though, results can be visible within a week. There have been some papers that suggest that it facilitates muscle activation. It can also help with spasticity, with relaxing muscles. It can help improve posture, and it's easy. So it is literally tape. Once you learn how to do it, someone near you or you can do this for yourself. So I encourage you to explore this a little bit. Now, this has been, neuromuscular electrical stimulation has been around quite a while. I'll talk about two different ways that it's used. So for neuromuscular electrical stimulation, the risks is that there's a cost for that equipment. And literally what you do is you put these electrodes on the muscle of interest. These electrodes are attached to this little box, which has a battery and has a few knobs on top. And the knobs allow you to change the parameters of the electrical signal that you're going to send to these electrodes. So it's literally a little bit of an electric stimulus that goes to the muscles to help them contract from an external source. Now, this has been used historically for people who've had more orthopedic injuries, which you can see this person has a scar here, so I'm guessing this was used for recovery from this surgery. The benefits, though, is that it can help strengthen a single or a very specific muscle. There's also evidence that it increases circulation to the area, and it's portable. So once you get trained from a licensed professional who can do this, a physical therapist, then you can bring this home, and this can be used as an exercise method as well. So the question is still out, though. These muscles are strengthened in a different way using this neuromuscular electrical stimulation. So is it as effective as being strengthened by regular focused exercise? And for AMN, that answer is still not available. Now, there's also something called functional electrical stimulation devices. Now, this works in a very similar way. There's three different options that I'm showing here. This is more the one version where you again have two electrodes attached to this little device here that has all these different parameters that allow you to shift the signal by its length and its amplitude so that you get the best response in the muscles that you're interested in. And it can go on and off depending on how you set up your walking speed. So really the only thing that makes this different from the previous slide is that this word functional indicates that it's been set up, all of these devices have been set up to be useful during the walking cycle. So this is called the Bioness. No, this is the Walk Aid actually, and this is the Bioness. They're very similar. Essentially they work by having an electrode put into the band of this device. This band is put around the top part of your calf, just below your knee. And this little box controls the stimulation that goes to this electrode. And we're maximizing the idea that your perineal nerve is very superficial on the outer parts of your leg just below your knee. And so this electrode will stimulate that nerve, and that nerve goes to the muscle that allows you to lift your toe when you walk. Do you remember that tibialis anterior muscle that I mentioned previously? This device is designed to make that muscle work when you're walking. You don't always want that muscle to be active, right? You don't always want it to be contracting. You only want the tibialis anterior to be contracting when you want to bring your foot forward so that your foot doesn't drop and drag, right? So there are lots of different companies out there that are willing to sell you this. I think it does make sense from an AMN perspective, though they're quite expensive. So let's go back to the risks and benefits of this kind of device. It's costly. So as a major risk, they're about $5,000 to $6,000 for one of these two devices, which are the devices that seem to be marketed quite heavily. This kind of device you can get from you can get it much cheaper, much less expensive, but it's not quite as it's a little bit different in that you're not timing this to your own specific walking. This is timed to a general walking pattern. Another risk is that just like the neuromuscular electrical stimulation device, skin integrity is an issue. It's pushing an electrical signal to your skin, trying to get at the nerve below the skin. Another risk is that it's time intensive. Oops, sorry. Time intensive meaning the only evidence that I've seen is really that it works well as long as you're using it. So that's what I mean by time intensive. So potential benefits, it can improve muscle bulk. There's evidence that it helps with bone density because you're pulling on the muscle that's pulling off from the bone, which stimulates the bone. It can improve circulation in your leg, and it can improve motor control. And I've seen kind of limited evidence for how it improves motor control, just to be honest. This has been used more heavily, this kind of technology has been used more heavily in spinal cord injury. But you could argue that AMN is spinal cord injury because it's not via trauma like many people, but there is damage to the spinal cord. So the question is, will it be as applicable in AMN as it has been for spinal cord injury? So I encourage you to explore this, but I would also encourage you to go to a professional before you purchase anything. The companies are there, and it's fantastic that they're available, but you want to go to someone who can evaluate you specifically and in a very individualized way, and then go explore options like functional electrical stimulation with that person, with a physical therapist. There's also functional electrical stimulation, not for walking, but for riding a stationary bike. So this is really effective for someone who is not able to walk, but still really wants to maintain muscle mass, improve circulation, helps with bone density, all those same things. This kind of device is very costly, but it is available. You can see the website below here. I believe it's like $18,000, and as far as I know, many of these devices are not covered by insurance, but don't take my word for it. I would definitely explore that with your insurance company. Oftentimes a letter of medical necessity can be written, and I can tell you in a handful of cases it has been covered. I haven't seen so much success with insurance covering the bike that I'm showing here, but with the other devices that help with foot drop that sometimes can be covered by insurance. And so my pitch is always, if we want these things to be available, we have to prove that they are effective in AMN. And so this is where I really believe in having research that is specific to ALD and AMN to show which interventions are most effective, and with the hopes that then insurance companies will get the idea that paying for this kind of device is a smart idea because it will allow you to stay healthier and stay mobile longer. but we're not at that point yet. So I would encourage you to find a professional to help you explore these options. Now there's also something called partial body weight support, and that's this big device here. And so this can be used at home or in a clinic, and it essentially has a harness system here, as you can see on this woman. And the idea is that the device can hold some of your weight so that you don't have to hold all of your weight, and this may allow you to walk more and build your muscle strength. So the risks is that it's this really bulky, large piece of equipment. You really need a skilled therapist, at least initially, to figure out how to make this work for you. These are commonly used. This can be used on a treadmill, can be used over ground. They're in many physical therapy clinics now. The benefits is that it could allow you to walk more when your legs don't have to support all of your weight. Often they can, this can help you build some muscle strength. It also provides the therapist, your physical therapist, with a tool so that they can focus on other issues without the high risk of you falling while you're walking with them. There's also a device called the Hip Flexion Assist device, and I show the website down here below. What this is, it's a really clever idea. You wear a belt, and these devices, these bands here are elastic, and they attach down here to your shoe and your leg. And the idea is the elasticity here and here helps you bring your leg forward each step. So it helps you flex your hip. And in AMN, what we found is that hip flexion is an issue. So this kind of device has a lot of potential for being effective in AMN. I have not tested this in a research study, but I'm just showing you this as an idea to give you ideas of other options for you. Now the risks, most people say it looks ugly. It's bulky like this. And you need time to learn how to use it because it does push you, it could actually push you off balance initially. So you want to do this carefully. But there are benefits. It assists you with hip flexion, so you can walk, potentially you could walk further wearing this kind of device rather than when you're not wearing the device. It's also cheap, not expensive, something your therapist can help you purchase. I've seen many patients make something like this on their own. And it allows you to walk with less effort. So I have had patients who have used this and then liked it. So I wanted to make sure I brought that up. There's also new robotic technology. I'm just showing a couple of examples of things that are available in therapy clinics now. And this is the idea is that instead of walking in a device that makes you move in a very calculated robotic way, this particular device is selling itself, at least, by saying it makes the kinematics of walking more normal than other robotic devices. So it's like you're walking on a treadmill, but really you're getting a lot of assistance from these foot pedals here. So the risks is that for any of these technologies, it's expensive, and you need to find a clinic, a specialized clinic that has them. Many spinal cord injury clinics have things like this, and AMN would be a perfectly reasonable thing to explore, to try to use with this kind of equipment. We don't have evidence for how effective it is in AMN or ALD at all, but it's something that you and your physician and your physical therapist could discuss and see what might be a good plan for you. Benefits, your legs have to support less weight. You can see this harness system on this gentleman here. The company claims the kinematics, so the movement of your hips and your knee and your ankle, are similar to overground walking, which is what you want, right? You don't want to just be able to walk in this device. You want to be able to walk over ground. And again, it allows the trained therapist to focus on other issues without risk of falling. Now, I want to talk, we're nearing the end of what I'm going to talk about, so I'll make sure I leave some time for questions, but I wanted to talk to you about this idea of body-worn sensors as well. So there are lots of varieties of this. I'm showing down here on the right, this is an actigraph watch that is FDA approved for research. What it does is there's an accelerometer in there that will record in 3 dimensions activity of and the activity is of wherever this little watch goes. So you can wear it on your wrist, and anywhere your arm is going, the accelerometer is recording what you're doing. Now, this can be very helpful. It's been, you know, there's the Fitbit and the Jawbone, and there's lots of different body-worn sensors available over the counter, and those are great because they give you step counts, so it gives you an idea of how active you are. I'm thinking these body-worn sensors though have a lot more potential than what we're using them for. The risks with them is that they're expensive. This is $250. The Fitbit is less expensive. I think it's around $150. Depends on where you are. It may miss activity though that doesn't require the whole body. The way the body-worn sensors are used today is that it's used very broadly to provide information about step information based on an algorithm mathematically that isn't specific to you, but is generally useful in the population. So we're missing some sensitive information that I think in research we could try to get at, which would help us understand walking intensity and walking variability and maybe change in walking ability over time. There are also potential benefits. It can be considered inexpensive, right? Compared to some of the equipment in the lab that I have, this is far less expensive. It's easily implemented broadly, so I can mail this to you and you can put it on your wrist just like you would a watch. It's motivating because you can see how much activity you've had in a day. So if you get to the end of the day and you're like, oh my gosh, I've hardly taken any steps today, that might motivate you to go on that extra walk or to get on your treadmill. I really believe that new analyses will provide more objective information about walking and total activity level, not only how active you are during the day, but how active you are at night and how that might affect your day. So I tell you this more as this is an area that I think needs a lot more research and I think has potential in AMN. Okay, so scientists are testing new rehabilitation approaches all the time. I really encourage you to read the literature you have available to you. Ask your physician, your nurse, your physical, your occupational therapist questions. Ask them about things. They are your experts. Stay current with what's being tested and how it's being studied. It may be appropriate for you to participate in a study, and you won't know if you don't ask. I want to acknowledge all the people that make my work, my research work, really possible. The many people at Kennedy Krieger. I work in a Center for Movement Studies, which has several laboratories in it. And also for ALD Connect for inviting me to share this information with you. If you want to hear more about what we do in the lab, I have a lab website that you can check out here. I want to be sure and thank all of the patients who so generously gave of their time to participate in our studies and has helped us learn as much as we know. I always want to give proper thanks to the Mosers, Hugo and Ann Moser, because I feel like they're sort of what inspired me to start this work. And this was our group at several years ago, maybe even like 10 years ago, but really makes our team really special at Kennedy Krieger. I'm willing to take questions if there are any, and then I have a disclaimer slide at the end. Thank you. I have a couple questions that I'm not sure I answered, so I'll start with those until I hear from questions online. So one person asked, I'd be specifically interested what portion of the legs are mostly affected with AMN, and if any studies or follow-ups are known as to how long it takes to lose control of the legs from the first symptoms. So I can tell you from my research, it seems as though the hips are a very important component of weakness in AMN. So that might be one area to focus on. I can also tell you from a research experience on sort of generality, so I don't know you specifically, but in general, it takes many years to lose total control of the legs, and not everyone reaches the same level. So I would, instead of focusing on when you're going to lose more control, I would really focus on what can I do now to help myself maintain the strength. So I hope that answers it appropriately. Let me know if you'd like to discuss more. Another person wrote in a question about ankle-foot orthotic devices, which I didn't cover, and it is a completely appropriate treatment option as well. And what this is, as I showed you, the tibialis anterior muscle is often weak, and so your foot drags, and it's hard to bring it forward with each step. So instead of using electrical stimulation, which is what I talked about, there are also these braces that you can wear that cover the bottom of your foot and go up the back of your calf about 2/3 of the way up. And what it does is it can hold your ankle at a specific angle. It can also, the newer devices actually add a little spring so that you can actually, it gives you a little bit more help with the push-off part of walking. I think it's definitely appropriate for AMN if you have this issue of foot drop. Many people don't like it because it's a little bulky, so you do have to, it isn't appropriate for all of your shoes because it is a device you're wearing. Most insurance will cover it, but you have to look for your insurance specifically. But I definitely would recommend this. It's a very good suggestion. The last question that I have written out here was, this was brought up by another part of our community here in ALD Connect, where I didn't really talk about the importance of a person's psychological and mental health and how that affects someone's walking. So I think it's really important to understand that your physical and mental health are very coexistent, right? So if you're depressed, or if you're giving up, or you've reached a point psychologically where you just feel like it's not worth trying more, then you need to get help for your mental health as well from a professional. But I will suggest that exercise may also help you with this idea of keeping your mental health appropriate with your physical health. So I appreciate the idea was really just the physical daily struggle of living with AMN is difficult, and so I'm encouraging you to move more, and I think that will help with your mental health. But don't forget that this mental health component is very important. Okay, so one question that's been put out here is, what treatment is best to reduce spasticity? So spasticity is this problem where you don't have voluntary control and your muscles get tighter. You might notice this in the morning. You might notice this when you're stressed or you're trying to move really quickly and you can't. That would be that this muscle tension is too much, and it's not anything you're doing voluntarily. This is purely a problem with the condition. So the best way to reduce spasticity is probably twofold. One, be sure that you're drinking enough water. Be sure that you're stretching, and that you're stretching the muscles that are tightening, because not every muscle will show an equal amount of spasticity or tightness. I also would recommend that you talk to your physician and your physical therapist to see. There are definitely medication options, but as always, medications have secondary side effects. So the first approach I would probably suggest is just to be sure you're drinking enough water and you're stretching, and trying to stretch slowly and to the right muscles. And if that isn't sufficient and you're still having lots of issues, then I would take it to your physician and say, what else is there? And there are medication options that you could explore. Another question that's come up is, so how to find a therapist in my area to help specifically with AMN issues? This is a problem. So here at Kennedy Krieger and at some of the other centers that are so much a part of ALD Connect, there are professionals that are experts in this idea, in what's appropriate for AMN. But most of the country and most of the world is going to be hard to find experts. So what I have tried to do is, from our research, we always publish the information we've gathered. And I've tried to share that with people that I've emailed and asked, what do I tell my physical therapist? What do I tell my physician about AMN? I think if you show them this published literature that I'm happy to share with you, that would help inform them of what we know so far. It's important to educate your professionals about this because it is such a rare condition. Okay, another question. What about foot pain? Or, and do you know anything that will help with that? So this has been an issue. We've run a study looking at ALD, specifically AMN women doing exercise, and we've noticed that the women overridingly seem to report more pain, and it is foot pain often. There's also pain in the legs and in the shoulders and in the neck, but we don't know how to treat individual pain as effectively as we want to. This is something that we need to explore. This is something I would take to your physician and make it clear that it isn't, it may be orthopedic, and so that would be the first thing to explore. Is the pain literally because now you've been moving differently for so long that you, maybe you are compressing a nerve somewhere in your neck or in your hip or in your knee in a way that is causing pain? Or is it purely because of the condition of AMN or ALD? And in that case, what are the options medically to deal with that? Because I'm sorry I don't have a better solution, but I do think pain is a really important issue that we need to study more. Can you guide us, another question, can you guide us to people who are researching bionic or robotic leg braces? You know, I've limited exposure with this. So I've seen there are spinal cord injury clinics all over the country, and many of them have scientists who are exploring different robotic leg braces, and I think it's something we should be exploring more. There's no active study that I'm aware of being done in AMN, so I would encourage you to explore the spinal cord injury clinics in your area or online and see what kind of devices they're using, because again, AMN is really a spinal cord disease that affects your spinal cord. So although it's not trauma like many spinal cord injury patients have experienced, you do have spinal cord injury, so many of the devices also could be effective. Another question regarding the bridge exercise. How long do you raise your hips off the floor, and how many repetitions? Okay, so this is I showed you an exercise kind of in the middle of my talk where I called it a bridge exercise. The person lays on their back, bends their knee, and then lifts their hip. And I talked about how it was really a great exercise for using your abdominals as well as your gluteal muscles. I purposely didn't give specifics about this because I think I can't do that very effectively because I have no idea what all of your abilities are. So I would encourage you, I give you this information as food for thought, and I encourage you to go to a physical therapist and be evaluated and ask them for you, how many repetitions should I do? What is the proper form for this? Because I don't want to give you improper guidance given that I can't see you or see how you're moving at all. Okay, another question, can we actually improve muscle strength in lower extremities once spinal cord damage has occurred in AMN? And can exercises improve foot drop, or will it be simply a case of trying to prevent more loss? So in other words, is there a tipping point where strengthening versus only maintenance occurs? And the person who's writing it says, I'm finding surprising improvement practicing martial arts stretches and moves with my kids and can do more now than I could last year. So I think that's exactly true. We don't know what the limit is. So I would say that we know from the study that we've just completed, at least in AMN women, we know that exercise can improve strength and some walking. We don't know what the dose is of exercise that's the most effective, but we do know that it can improve walking, and so therefore it could improve foot drop if you're strengthening the appropriate muscles. There must be a tipping point where strengthening is not helping, and I'm sure many of you in the audience may have that experience where you feel like you've tried and you're not making gains or not making them fast enough. And so one question I would have for you is, what dose of exercise are you doing? Are you doing strength training as well as endurance exercise? And are you getting guidance from a professional like a physical therapist or an occupational therapist who can evaluate you in a way that can help determine which exercises you should be doing and to what dose and how many repetitions, that kind of thing. So I agree with the person who's asking the question. I think most of you will find surprising improvement if you're very diligent. But just like a medication, if you stop doing the exercises, if you stop exercising, you will lose strength, just like anybody else would. So it's a matter of being very, very consistent. And this is where I think having the professional guidance to keep you honest and obligated to do it is very helpful. Okay, another question. How do you find a therapist in my area who can help specifically with AMN issues? And can you guide us to people who are researching? Oh, we already answered that. So the best way to find a therapist, I don't know if I answered that specifically, the best way to find a therapist in your area is to go, I would go to your physician, ask them if they have a physical therapist that they work with, or an occupational therapist if you want more functional activity versus strengthening. If your physician doesn't have a specific person they work with, many times you can ask people in your area. You could also call rehabilitation hospitals in your area. They're not going to know about AMN predominantly, but if they have a background in neurology, then you can teach them what they need to know, what we know so far at least. And that's kind of the best case scenario that we have right now. Outside of coming to one of these clinics, like at Kennedy Krieger, we do have a clinic where you can come in and have a thorough evaluation with a physician and a physical therapist. That's impossible, though, if you're living far away. So I encourage you to look for resources in your community. If you don't have them, look for resources outside of that community, and then narrow it down to people who are your best option, even if they're not specifically experts in AMN. Another question, are MS meds at all helpful, especially with treating the spasticity? That's a really good question. So multiple sclerosis is a very different pathology than AMN, but if you end up, many people end up being misdiagnosed initially, with people thinking they have multiple sclerosis when they really have AMN. And that is in part because we really struggle with the phenotype or the description of how people can start acquiring symptoms. So I'm not the expert to ask about medications, but I think this is something you could ask your physician. Spasticity medications essentially help decrease the muscle tone throughout your body. So this can be helpful in MS as well as AMN. So it's a very relevant question, and this is something I would take to your physician. Are there other questions? I can't see any others coming through. I don't know why I can't see them, but so I'm going to go to the next slide, which is, again, the disclaimer. I want to be very clear that the information and services provided by ALD Connect are for informational purposes only. They're not intended to be substitutes for professional medical advice, diagnosis, or treatment. We want you to, if you or a family member are ill or suspect that you or a family member are ill, please seek professional medical attention immediately. ALD Connect is a wonderful resource, but it doesn't recommend or endorse any specific physicians, treatments, procedures, or products, even though they may be mentioned on my slides. Please note that your participation is voluntary. This webinar, it has been recorded and may be available for rebroadcast at a later time. Oh, there's another question. Is there an AMN support group online? So ALD Connect doesn't have one, but I believe the ULF, the United Leukodystrophy Foundation, does, or knows of an AMN group that exists, so you can contact them. Definitely the United Leukodystrophy Foundation would be a good resource. And you know, maybe this is something that needs to be started if there isn't something already available. So if you've looked, whoever's asked the question, if you've looked and you feel like there isn't one, then maybe that would be the call for you to start something like that. There's also a survey. Please answer the short survey that you'll receive after the webinar. And if you, for further feedback, please email all your questions or comments or concerns to this ALD Connect website here. And I'm happy to answer questions if there are any additional ones. Thank you all for listening.